If you're like most people, you've probably heard horror stories about the side effects that can be caused by chemotherapy. There's no question that chemotherapy can be quite unpleasant for some people, but by other people it may be very well tolerated. In this video, I will discuss why chemotherapy plays such an important role in the treatment of cancer and why many people will decide to take it despite any unpleasant side effects. In a later video, I will actually discuss the potential side effects of chemotherapy, what they are, and what we can do about them. My name is Dr. David Stewart. I'm a medical oncologist in Ottawa, Canada, and a professor of medicine at the University of Ottawa. And I recently wrote a book on cancer intended for patients called A Short Primer on Why Cancer Still Sucks that can be purchased online if interested through Amazon Books. This is the 6th out of 16 videos I'm putting together on different topics that people ask me about fairly frequently about cancer. And for additional details, you can see my book. Importantly, you should rely on the advice from your own healthcare advisors for anything related to your own personal health. Chemotherapy generally kills cells either by damaging the DNA, the genetic material of DNA in the cell, or by interfering with the production or repair of DNA, or by damaging another key structural component of the cells called tubulin. Chemotherapy drugs can kill both normal cells and cancer cells, but for individual types of either normal cells or cancer cells, the probability of them being damaged or killed by chemotherapy will depend on characteristics of that particular type of cell. So there's some cells that might be very sensitive to a certain kind of chemotherapy and others that will be highly resistant. A chemotherapy drug that's highly effective against some types of cancers may have no impact at all on others. A chemotherapy drug will generally only be useful if it is more toxic to cancer cells, at least some cancer cells, than it is to normal cells. If this is the case, then it may be able to control the cancer or shrink it at doses that are tolerable to patients with respect to toxicities to normal tissues and side effects. If a cancer is already widespread or metastatic, it will generally not be curable by any type of treatment, by chemotherapy or anything else, although there are a few exceptions. Cancers that can be potentially curable in at least some patients, even if widespread, include some kinds of leukemias and lymphomas, testicular cancer, and a few others. For the more common cancers that cannot be cured by chemotherapy, the chemotherapy may nevertheless be able to kill some of the tumor cells. If the chemotherapy is successful in making the cancer shrink, then it may improve the symptoms from the cancer. Symptoms like loss of appetite, pain, cough, shortness of breath, and things like that. And if chemotherapy makes a cancer shrink just a little bit, that can sometimes be a much more potent analgesic than morphine. While chemotherapy can cause a lot of side effects, many people find that the trade-offs are worth it. By improving the cancer symptoms, the patient's quality of life is improved despite any side effects that the chemotherapy may cause. By shrinking the cancer, the chemotherapy can also prolong life expectancy, although we can never predict how much it will prolong life expectancy in an individual patient. In some patients, a type of treatment may not work at all. In others, it may work very well. So I typically tell my patients they have to be prepared for the fact that no matter what we do, things may worsen very rapidly and life expectancy may be very short. But on the other hand, the treatment may work very, very well on them, and we may possibly be able to control the cancer for 2 or 3 years or longer. Therefore, it is very important that they live one day at a time. Generally speaking, if chemotherapy shrinks the cancer enough to prolong life expectancy, it will also improve symptoms. So not only do patients live longer, but also the quality of life is generally improved as well in those patients who have major tumor shrinkage. Because we can never predict the degree of benefit or side effects in a given individual patient, I tell my patients that there is no right answer with respect to whether or not they should take chemotherapy. The right answer for them is what their gut tells them to do, and we will fully back them no matter which way they decide. It would be easy if I could just predict what was going to happen, but because I can't, these decisions can be very difficult for some patients. But it's also important to understand that patients who are facing an incurable illness, who are looking down the gun barrel, will suddenly look at things much differently than somebody who is healthy. So patients will frequently tell me that they've always said that they would never take chemotherapy, but then when they're actually facing a lethal illness, it's going to kill them in a very short period of time, and it's causing them very major symptoms, then they will look at things much, much differently. As I said, sometimes chemotherapy can prolong life expectancy by 2, 3, 4, 5 years or more. Sometimes any gain in life expectancy may be far shorter. It may just be a few months. But for some patients, that will be very important. So it may permit them to see their daughter's wedding, or the birth of their first grandchild, or their son's graduation from college, or one last Christmas. So these things that can suddenly become very, very important when life expectancy is suddenly very, very short. I also try to make sure that patients know what the alternatives are. So that, for example, to improve symptoms, we work very closely with palliative care physicians, and they are very close allies. And if patients decide not to take chemotherapy, or if chemotherapy is not working, then palliative care physicians can be quite helpful in helping control symptoms. Although, as I stated, if we can make a cancer shrink, that can be a much more potent analgesic than any narcotic can. Radiotherapy is also very helpful. And again, we work very closely with our colleagues in radiation oncology. So again, if chemotherapy is not working, or the patient is not a candidate, or the patient decides not to take chemotherapy, then radiation can be very helpful in improving symptoms. Although for widespread metastatic cancers, radiotherapy typically has far less impact on life expectancy than chemotherapy does, but it can be very helpful in controlling symptoms. Typically with chemotherapy, if the chemotherapy is going to work to shrink the cancer, the greatest shrinkage is in the first 2 or 3 cycles of chemotherapy, and after that, the tumor may stabilize. In some cases, it may only remain stable for a very few weeks or months before it begins to regrow again, despite the chemotherapy. In other cases, it may stabilize for several months or a year or 2 or longer. We generally cannot predict at all in an individual patient the degree of benefit or how long that benefit is going to last. The reason we cannot cure most widespread cancers with chemotherapy is that the cells that survive the initial chemotherapy typically develop resistance mechanisms to prevent killing. So in some cases, they may be sensitive enough that they're sitting there and not growing, that the cancer is not growing, but we cannot actually kill the remaining cancer cells. If a cancer grows despite the chemotherapy or is resistant to it, or if it shrinks for a period of time and then begins to grow again because of development of resistance, then other chemotherapy drugs may be helpful. Although the things that make a cancer resistant to one kind of chemotherapy will often also make it resistant to other kinds of chemotherapy as well. So the probability of tumor shrinkage is lower in a patient who has previously had chemotherapy than in somebody who's never had chemotherapy before. But nevertheless, for some patients, second-line treatments or third-line treatments can be of benefit for some people. And again, we cannot predict in individual patients. In patients who have undergone surgery to try to cure a cancer, then the surgery may cure it, but there may be very small tumor deposits that are too small to show up on any of the scans that will survive after the main tumor is removed, but will grow later and show up as incurable distant metastases. So if we give chemotherapy to somebody who has undergone surgery and who is at a fairly high risk of the cancer coming back, for many types of cancer, giving that chemotherapy after surgery, so-called adjuvant chemotherapy, may improve life expectancy and may improve the probability of long-term survival. The degree of benefit of adjuvant chemotherapy given after surgery varies across tumor types and across situations and across patients. But typically where it works, it will improve the probability of long-term survival by somewhere between 5% to 15%. Some patients would consider this worth it, and some people do not consider it worth it. So again, what I do is I tell the patients what the probability of benefit is, what the side effects are, and that there is no right or wrong answer, and that we will fully back them no matter which way they decide, and that the right answer for them is what their gut tells them to do. In some patients, chemotherapy may be instead given prior to surgery in the hope that it may kill off those small metastases we cannot see before the surgery is done. Chemotherapy given prior to surgery is referred to as neoadjuvant chemotherapy. And in most situations, we just do not know for sure whether giving chemotherapy before surgery is more effective or less effective, or just as effective as giving after it. So there are different things that are taken into consideration in offering neoadjuvant chemotherapy versus post-operative adjuvant chemotherapy. Also, if a patient is potentially curable by radiotherapy, then giving chemotherapy with the radiation may improve the chance of cure. And again, typically by about 5% or so. And it does this by making the radiotherapy work better against the tumor cells that are hit by the radiation, but it also can kill off small tumor deposits that we cannot see on the scans that are outside the path of the radiotherapy beam. Again, some patients decide to take chemotherapy with radiation. Some people decide not to. Again, I tell them there is no right or wrong answer about whether to take the chemotherapy with it or not, and we'll fully back them no matter which way they decide. So there are different ways of giving chemotherapy, but most frequently it's given into the vein once every 3 weeks. And the reason it's typically once every 3 weeks is that that's how long it takes for white blood cells that are damaged by the chemotherapy to go down and then recover again to the point that it's safe to proceed with the next treatment. However, for some individual types of chemotherapy, we may give them once a week instead of once every 3 weeks, or one day and again a week later out of every 3-week period. Or we may give some by mouth instead of giving them intravenously. This all depends on the characteristics of that particular chemotherapy drug. As I mentioned earlier, I discuss side effects of chemotherapy in a later video, and also I discuss it in detail in my book. And if you want more details, again, you can see my book, A Short Primer on Why Cancer Still Sucks, that can be purchased online through Amazon Books. I hope that you have found this video helpful. Thank you.